Intussusception. Key points. The diagnosis of intussusception requires a high index of suspicion. Consider intussusception in infants and children with intermittent distress, vomiting or isolated unexplained lethargy. Delayed presentation of intussusception can manifest as small bowel obstruction, bowel perforation, peritonitis, and/or shock. Ultrasound is the initial study of choice. Background. Intussusception is the invagination, telescoping, of a proximal segment of bowel into the distal bowel lumen. The commonest site is a segment of ileum moving into the colon through the ileocecal valve. This process leads to bowel obstruction, venous congestion and bowel wall ischemia. Perforation can occur and lead to peritonitis and shock. The triad of intermittent abdominal pain, palpable abdominal mass and red currant jelly stools occurs in only 1/3 of children. May occur at any age, but most commonly between 2 months and 2 years of age. Most cases are idiopathic, 90%. In older children, a pathological lead point may be the cause. Assessment. History. Intermittent pain or distress. Episodes can recur within minutes to hours and may increase in frequency over the next 12-24 hours. The child may appear very well between episodes. Pallor, especially during episodes. Lethargy may be the only presenting symptom. It may be profound, episodic, or persistent. Vomiting is usually a prominent feature, but bile-stained vomiting is a late sign and indicates a bowel obstruction. Diarrhea is quite common initially and can lead to a misdiagnosis of gastroenteritis. Rectal bleeding, or the classic red currant jelly stool, are late signs suggesting bowel ischemia and infarction. Additional risk factors. Recent intussusception may present with more subtle symptoms. Potential lead point, e.g. Meckel's diverticulum, Henoch-Schönlein purpura, lymphoma, luminal polyps, e.g. Peutz-Jeghers syndrome, recent bowel surgery, recent rotavirus vaccination. Examination. Abdominal mass may be felt, typically a sausage-shaped mass in the right abdomen, crossing the midline in the epigastrium or settled in between episodes. Behind umbilicus, in 2/3 of children. The abdominal mass may be subtle and examination is best performed when the child is settled in between episodes. Abdominal distension suggests bowel obstruction. Tenderness or guarding may suggest perforation and peritonitis. Inspection of the nappy and perianal region should be done. A rectal examination is rarely indicated. Infants may present with hypovolemic shock. Management. Analgesia and resuscitation should precede investigation, see flowchart below. Secure for access for all children suspected to have intussusception before diagnostic imaging. Treat hypovolemic shock with 4 boluses of 20 ml/kg normal saline. Blank. Involve the surgical team early. Keep nil orally. Pass nasogastric tube if bowel obstruction or perforation on AXR, or if planning transfer by air. Children with intussusception can decompensate while undergoing ultrasound and/or air enema. Ensure medical or nursing escorts are capable of providing resuscitation if needed. Investigations. Ultrasound scan. High sensitivity, and GT 98%, and specificity, and GT 98%, when performed by an experienced pediatric ultrasonographer. Point-of-care ultrasound can be used to confirm the diagnosis of intussusception by appropriately trained clinicians. Should not be used to exclude the diagnosis. Abdominal X-ray. Perform AXR only if there are signs of obstruction or perforation. A normal AXR does not exclude intussusception, sensitivity and LT 50%. Signs suggesting intussusception on an abdominal X-ray include an abnormal gas pattern, with an empty right lower quadrant and visible soft tissue mass in the upper abdomen. A soft tissue mass surrounded by a crescent lucency of bowel gas, crescent sign. Lack of fecal material in the large bowel. Signs of small bowel obstruction. Pneumoperitoneum, indicating bowel perforation. Contrast/gas enema. The enema may be used diagnostically and therapeutically in consultation with a surgical team. There is a small risk of bowel perforation and bacteremia during the gas enema. Therefore, the enema is performed where pediatric surgery is available in case of the need for laparotomy. Usually, a surgical doctor, as well as a suitably trained nurse, will accompany the child with appropriate resuscitation equipment. Contraindicated if peritonitis, shock, perforation, or an unstable clinical condition is present. Blood tests. Blood glucose, venous gas, FBE, and UEC if the child looks unwell. Blood group and hold prior to theater. Consider consultation with local pediatric team when there is suspicion of intussusception. All suspected cases. Consider transfer when child requiring care beyond the capability of the hospital. Note: when transferring infants or children with possible surgical conditions, ensure they have adequate analgesia, venous access, intravenous fluids prior to transfer, as third space losses can be large and lead to hemodynamic collapse. Consider a nasogastric tube on free drainage if transferring by air.